Hello, everyone. Good morning and good afternoon, and thanks all for joining to this Biocartis webinar. The topic of today will be SeptiCyte RAPID in COVID-19 patients suspected of sepsis. And this talk will be hosted by Dr. Roy Davis, who is Chief Medical Officer at Immunexpress. Before starting, few practicalities. So the session will be recorded, and you will receive a link to the recording in few days through your email, or it also can be found on our website. In case you would have any questions during the talk, please do not hesitate to use the question box in your control panel, and all questions will be handled at the end of the session. I wish you all a very nice session and will give now the floor to Roy Davis to start the talk.
Good afternoon. I appreciate you taking time to join us and hope we'll have some questions at the end that we can make a discussion out of this. My name is Roy Davis, as said, and I'm the Chief Medical Officer for Immunexpress. What we'd like to do today is, slides aren't moving.
Click one more time in your PowerPoint presentation, Roy, so that you are active in the PowerPoint presentation.
There we go. Thank you. So what I'd like to do today is, from a standpoint of COVID-19 and how it presents and its relationship to possible sepsis. As you know, there is no gold standard for sepsis from the standpoint of diagnosis, and clinically COVID-19 presents in multiple forms. We'd like to review COVID-19's impact on sepsis epidemiology in general, and also the similarities between COVID-19 and bacterial sepsis, both biologically and clinically. Recap SeptiCyte RAPID's technology, its validation, and the platform that we use, and then look at the severity of COVID presentation as a proxy for sepsis and the role of SeptiCyte RAPID in risk stratification of COVID-19. Also look at predicting a need for ICU admission compared to other biomarkers in COVID-19 severity. And then a review of a couple of cases of COVID-19 and the role of SeptiCyte RAPID, how it can be used in that. It was not very long into the COVID pandemic that Dr. D. Halley, in a meeting at the Sepsis Association meeting in Europe in March of 2020, made the statement that COVID-19 is not just an infection, but is viral sepsis. And I think that was an important process from the standpoint of recognizing this disease and its similarities to the presentation of a bacterial sepsis. Sepsis mortality and morbidity has almost doubled since the onset of COVID. WHO reported that there were 3.3 million COVID-19 deaths in 2020. An estimate of 1 million of these are due to COVID viral sepsis. Interestingly, just yesterday, the total worldwide COVID deaths are now up to 6 million. Pre-pandemic sepsis was the leading cause of deaths in US hospitals, with about 270,000 deaths per year, which in 2020 increased to 440 deaths. With regards to sepsis overall, sepsis survivors are often disabled. They require acute and long-term care and have lower quality of life post-sepsis. This brings to mind long COVID and its description. What are the similarities between bacterial sepsis and COVID-19 illness as it presents? Bacterial sepsis has been described as 3 phases. There's an early phase, and when one looks at COVID-19 and bacterial sepsis, there are marked similarities in the early phase. It's characterized by a severe inflammatory response. It's a response that's initiated by cytokines and may lead to a sudden whole body release of bioactive proteins called the acute phase response. There is a mid-phase in bacterial sepsis, and critical COVID illness has a very similar process. This is when the cytokine storm and acute phase response results in multiple organ damage and organ failure. And then the late phase of sepsis is characterized by profound shifts in white cells and T cell exhaustion, which is seen both in COVID and bacterial sepsis. When one looks at the early phase of bacterial sepsis, comparing it with COVID-19 illness, the cytokine release and acute phase responses are very similar. There's an early manifestation of sepsis is cytokine storm, which is typically seen in severe COVID-19 and is similar with regards to its systemic inflammatory response or cytokine release syndrome that's been described. Interestingly, a similar response was seen in those patients who died of SARS-1 and MERS in 2017. And when one reviews the severe inflammatory response that was seen in the 1918 and 2009 influenza pandemics, a similar response was noted. The cytokine release syndrome in COVID-19 is described as the early phase and is shown in this portion of this diagram, showing early release of the cytokine storm with IL-6 and IL-1 and resulting in increase in CRP, fibrinogen, haptoglobins, and thrombocytosis, which are all seen both in bacterial sepsis and in COVID-19 severe illness. In the mid-phase, bacterial sepsis and COVID-19 share multiple organ failure phenotypes, which we see both in bacterial sepsis, where we have onset of organ failure requiring intervention, and with regards to COVID-19, the WHO recently, over the last 2 years, has published multiple severity indices, the last one showing that those patients with critical COVID have under their breakdown of criteria, sepsis and septic shock, paralleling the process of bacterial infection as seen with bacterial sepsis. The late phase of bacterial sepsis, both COVID-19 and bacterial sepsis have altered T cell function and major changes in neutrophil subpopulations. T cell exhaustion is seen both in bacterial sepsis and in COVID-19. Neutrophil activation in these two disease processes are very similar, with increase in concentration of circulating neutrophils, and absolute neutrophil counts in both these diseases have activation, infiltration into tissues, and creation of neutrophil extracellular traps, both very similar processes in bacterial and COVID illness. This is also described in the diagram I previously showed on the right-hand side, with reduced T cell response and cytotoxic activity resulting in cell death and breakdown. So in review of SeptiCyte RAPID technology, SeptiCyte RAPID, as you know, is a gene expression assay. It measures the response of 2 host genes in responding to the presence of systemic infection. It differentiates sepsis from SIRS and is reported as a clinical risk score of probability of sepsis with a range of 0 to 15. The test has actionable results with a turnaround time of about 60 minutes. And importantly, it's independent of disease severity or causative pathogen. So we don't have to wait for the pathogen to be actually detected. SeptiCyte RAPID technology has been validated in a number of different papers and or poster presentations. An initial paper presented on the critical ill patient in ICU with sepsis was a multi-site study published by Miller et al. There has since then been a pediatric pilot study demonstrating the efficacy of diagnosis of sepsis versus SIRS in pediatric patients using SeptiCyte RAPID. A paper on evaluating patients post-major gastrointestinal surgery for possible development of hospital-acquired sepsis was reported by Verboom. And since then, there is also a paper on ICU patients with acute respiratory infection. This is a group of patients that we struggle with regards to the diagnosis of sepsis and was published using SeptiCyte RAPID. A number of posters have been done, including the one that we'll describe in this paper, in this presentation, COVID-19 patients by Hardy and Werben. Patients with malignancy and immunocompromised presentation was done, looking at patients' response to sepsis when they're immunocompromised and the results of SeptiCyte RAPID. And then a small study on candida sepsis was presented using SeptiCyte RAPID as a diagnostic. So a number of papers have been presented validating the role of SeptiCyte RAPID in the diagnosis of sepsis. SeptiCyte RAPID, as you know, is performed on the Biocartis IDILA platform. It has a 2 minutes hands-on time with regards to preparation and a 60-minute turnaround time. The turnaround time is fully automated process using a disposable cartridge with results that are actionable at the time of reporting. Patients with SARS-CoV-2 present in a 3-phase process from the standpoint of they have a pre-symptomatic or asymptomatic process. That is, the upper respiratory tract is infected by the virus in the ACE2 cells, and this may remain as the localized infection or may progress to the second phase, which is symptomatic early phase process, where the virus infects the lower respiratory tract and the alveolar epithelial cells, and the patient develops evidence of pneumonia. Over the next 7 to 10 days, patients may progress or improve, and if they progress to a severe disease process involving disruption of the epithelial and endothelial cells in the lungs and release of virus and cytokines as described in our earlier 3 phases of sepsis. We see SeptiCyte RAPID as being used as a diagnostic process in the period between the early phase and the late phase onset of severe disease, and may help us in determining the presence of severe disease in these patients. How do we see SeptiCyte RAPID being used in the clinical workflow with regards to COVID-19? Those patients who present with symptoms that we're all now familiar with, fever, chills, cough, SIRS criteria with regards to respiratory rate, heart rate, and decreased saturation, and other risk factors that put these patients at risk for this disease, age, comorbidities, and exposure. Those patients then have a SARS-CoV-2 test. If this is negative, continue evaluating this patient for other etiologies of disease, including bacterial sepsis and other possible etiologies. If SARS-CoV-2 positive, then we suggest we undertake a SeptiCyte RAPID test to determine the severity of this disease process. When we use severe COVID-19 as a proxy for sepsis, these patients would present with SIRS criteria. If they have presence of dyspnea, respiratory distress, O2 saturation, pneumonia on chest X-ray, they would progress into a further development phase. If none of these are present, they may have mild bacterial sepsis or mild COVID. Those that present with those findings may also have evidence of respiratory failure, ARDS, shock, metabolic acidosis, and organ dysfunction. These patients progress to a severe critical sepsis or COVID disease. Those that don't have these findings may have mild sepsis or moderate COVID requiring intervention from a management standpoint. WHO COVID-19 classification of disease severity has been used in a number of papers to describe this population of patients with COVID-19. As I presented earlier, the WHO breaks down the COVID severity into non-severe, severe, and critical. And under the critical group, there's a group of sepsis, septic shock. And it's this group that we think SeptiCyte RAPID has a major role in making a diagnosis and prognosis from the standpoint of severity of illness. In the studies that have been done on COVID-19 using SeptiCyte RAPID by Hardy and Bourbon, they broke this severity down into 4 groups: mild, moderate, severe, and critical. The severe and critical group are requiring high flow nasal cannula and or requiring life-sustaining support such as mechanical ventilation, shock, and organ failure intervention. Using this classification, one is able to break down the role of SeptiCyte RAPID in helping make this diagnosis. In the poster presentation by Hardy Bourbon, one can see that patients were broken down into critical, severe, moderate, and mild, and had a SeptiCyte RAPID test performed on admission. When one looks at this, one sees that those patients who were classified as critical based on the criteria I just presented, patients had scores that were high. Those patients with severe disease also had moderately high elevated SeptiCyte RAPID scores, but the moderate and mild patients who presented to the hospital had lower SeptiCyte RAPID scores, with scores generally in the 5 to 6 range. It's important to note that these patients in the severe critical disease area, some of them may have comorbidities and had low scores because they did not have severe COVID disease, but comorbidity complications. Those with higher scores surmised that they probably had COVID sepsis related to their COVID disease presentation. An interesting part of this presentation and poster presentation by Heidi Bourbon was that a number of patients were admitted directly to the floor with COVID disease. They had SeptiCyte RAPID performed on admission. A total number of 56 patients were admitted to the floor, but during their disease progression process, 29 of those patients were transferred to the ICU. Their SeptiCyte RAPID scores, as presented here, showed that they tended to have higher SeptiCyte RAPID scores than the group of patients that remained without severe disease and remained on the floor, suggesting that SeptiCyte RAPID could detect those patients who had progressive disease and would require increased intensive care during their hospital stay. SeptiCyte RAPID was looked at also comparing the other tests that we tend to use with regards to differentiating patients who have severe disease. These patients had SeptiCyte RAPID done within 1 to 2 days of admission and were positive for SARS-CoV-2 using PCR or antigen assay. There were 113 patients and evaluated from the standpoint of what tests separated those with critical severe disease from moderate to mild disease. And can be seen here, SeptiCyte RAPID had an area under the curve presentation of 0.73 compared to all the other tests that were lower than that to differentiate critical disease from moderate and mild disease, suggesting that SeptiCyte RAPID can be used to assess the risk of progression to severe disease much better than anything we have available at the present time. We also collected data from a number of sites with patients who presented with SARS-CoV-2. There were sites in Barcelona, Croatia, and Peru, with a total patient count as shown here, 149 from Barcelona, 11 from Croatia, and 46 from Peru. These patients were chosen because they had a breakdown from the standpoint of severity of disease criteria and were able to be broken down into the mild, moderate, severe, and then a group of patients who were classified as severe but were not admitted to the ICU were included in the severe group. As you can see, SeptiCyte RAPID scores on the IDELA platform differentiated clearly the severity of disease as it progressed from mild disease through moderate disease to severe non-ICU admission, and then severe COVID ICU admission, showing that SeptiCyte RAPID clearly differentiated these patients from a disease severity standpoint presentation, suggesting that this group of severe patients probably had evidence of secondary COVID-19 viral sepsis and or possibly bacterial sepsis in some cases. An interesting group of patients were studied by radiology using CT lung scans to classify patients from a severe disease standpoint, taking those patients that had the CT scan done and looking at their SeptiCyte RAPID scores and comparing the classification of this group based on their radiological severity of critical, severe, extensive, moderate, and mild. One can see that SeptiCyte RAPID again was able to differentiate those patients that had a severe disease by having a high SeptiCyte RAPID score, generally in band 3, from those patients with mild to moderate and or extensive disease based on radiological CT scan findings. Classifying those down into a smaller group where we put the critical and severe group together. The N's obviously are not large, but again, SeptiCyte RAPID was able to demonstrate that those patients with critical or severe disease by CT scan classification of their lungs had high SeptiCyte RAPID scores, suggesting again that these patients had severe disease, possible viral and or bacterial sepsis. This has prognostic criteria implications for this with regards to the treatment of these patients. The WHO presents guidelines for treatment, and NIH also does the same. And this is the NIH severity assessment and pharmacological interventions suggested based on criteria presentation. And as you can see, those patients with severe and critical disease, it's recommended that antivirals and steroids be included. Recently in February of 2022, these guidelines have been updated, and an antiviral has been included in those patients who have moderate disease, and suggested that we use ritonavir, which is a new antiviral with or without remdesivir. So these changes occur on a regular basis based on recommendations, but shows that the ability to diagnose severity of disease and or possible progression may have implications with regards to early intervention and treatment of these patients at the time of presentation based on their SeptiCyte RAPID score. Giving a couple of examples that are presented of patients who have been seen with COVID-19. This is a 59-year-old male who presents to the ED with a history of fever. Further evaluation had symptoms for approximately 36 hours. A physical exam showed mild tachypnea, and workup included a SARS-CoV-2 test, a white count and chest X-ray, and SeptiCyte RAPID was obtained. Looking at SeptiCyte RAPID scores of possibilities, this patient had SARS-CoV-2, was flu negative, elevated white count, chest X-ray suggested mild pneumonia. If the septic score was less than 7.3, there's decreased risk of severe disease and or progression, and a patient can be monitored and evaluated for possible bacterial pneumonitis and treated as such. Should the score be 7.4 or greater, this patient has great risk for progressive disease, increased risk of viral and or bacterial sepsis, and needs to be monitored for evidence of organ failure, and then consider early intervention from an antiviral standpoint using things such as remdesivir and dexamethasone. Another patient is a 62-year-old female who arrived at the emergency room with an ambulance with a 5-day history of fever, shortness of breath. This patient has a past history of hypertension. A physical exam showed a dehydrated patient on nasal cannula with poor cap refill. Chest X-ray was abnormal. Patient was started on IV fluids with boluses, and admitted orders were written. Patient was evaluated for possible sepsis with blood cultures, and SARS-CoV-2 antigen test was done, and a SeptiCyte RAPID was performed. This patient has multiple comorbidities and could be evaluated for multiple things besides COVID, including brain bleed with the presence of mentation changes. Having had SARS-CoV-2 positive patient with SeptiCyte RAPID scores. If the SeptiCyte RAPID scores again are in band 1, this patient has decreased risk of severe disease and does not have evidence of sepsis, and should be treated for secondary bacterial pneumonitis, possible a monoclonal antibody for SARS-CoV-2, but is at low risk for progressive disease. A high score in SeptiCyte RAPID would suggest the risk for increasing severe disease, increased risk of possible sepsis, and possible early intervention with antivirals, including remdesivir and dexamethasone. So its role of SeptiCyte RAPID can be seen in these two cases to impact clinical intervention. So in conclusion, there's multiple published references describing the similarities of COVID-19 to sepsis, especially in those severe cases. The ability of SeptiCyte RAPID to detect bacterial and viral sepsis is relevant because of this increased sepsis incidence during the COVID-19 pandemic. SeptiCyte RAPID can address the challenge of triaging those patients, especially those admitted to the floor with mild disease who are at risk for progressive disease, by having a SeptiCyte RAPID score that is elevated in band 3. SeptiCyte RAPID is clearly able to differentiate critical severe cases and needing ICU admission, as demonstrated by the AUC of 0.85. And SeptiCyte RAPID also outperforms the other individual biomarkers that we use frequently, CRP, lactate, monocytes, CD16, etc., for risk stratifying COVID-19 patients. So we surmise that SeptiCyte RAPID, as demonstrated, can be used to test COVID-19 patients suspected of viral sepsis and at risk of progressing to critical illness. I want to thank you for joining us, and we'll answer any questions if available.
Thank you, Roy. I see a few questions. First question, would you use SeptiCyte RAPID really as triage tool to decide if the ICU is needed? Also now when less impact on ICU beds since the decrease of the pandemics.
Yeah, I think that ICU criteria obviously stand alone frequently with regards to who can go to ICU. But I think that SeptiCyte RAPID could guide one to suggest, especially on those patients that you don't admit to the ICU, who may require closer monitoring and or intervention early, as suggested by that small study of patients who eventually ended up in the ICU. I've always felt that ICU admission is a clinical decision, not a test decision, but I think that SeptiCyte RAPID can guide you on those patients who may progress to severe disease and need to be closely monitored for those processes.
Okay, thank you. And the second question, if it's advised to use rather the Septis scores or the band interpretation?
I think that my drive is that the Sepsis scores have more relevance from the standpoint of they correlate with the probability of sepsis. The higher the score, the higher the probability of sepsis. For example, a score of 11 has an 82% probability of sepsis. As that score goes up higher in the 12 to 14 range, you're getting into 100% probability of sepsis. So I think the scores are more important. The bands at least put you in the general role of band 3 patients have a high risk, band 1 patients are low risk, and those band 2 patients, in conjunction with other tests, one can determine whether one needs to intervene with antibiotics and or appropriate antivirals if necessary.
Okay, thank you. I see no further questions. So then I'd like to thank you, Roy, for the nice presentation, and also all the attendees for being here in our session. And soon you will receive the link to the recording. Wish you a very nice rest of the day. Bye, everyone.
Thank you.
Thank you all.